Hello everyone, today we are going to discuss a very important topic and a very common presentation in the ER, pneumothorax. So what do you see in this X-ray? As the name indicates, this is pneumothorax, but what exactly is pneumothorax? A pneumothorax is a collection of gas or air in the pleural space that results in a variable amount of lung collapse on the affected site. So this is the X-ray of a real patient that presented in the emergency department during my shift. He was a 63-year-old male, known case of COPD, and his complaint was that he was completely fine in the morning when he suddenly started coughing, just like the usual cough, but slightly more aggressive. And after that, he has been experiencing shortness of breath. He was a known case of COPD, which means he had chronic bronchitis and emphysema as well. He was also a known chronic smoker. So when we did his X-ray, this is the picture that we had. Now this X-ray is typical of a COPD patient where you see that the hyperinflated lung fields can be seen, which means that the size of the lungs is more, or they seem like they are inflated like a balloon as compared to a normal person. And also the heart is elongated. It is not the typical shape of a heart where the inferior surface rests on the diaphragm. It is more elongated. Just like we see in a case of COPD, the hyperinflated lungs, they push the heart towards the center. So this is the picture that we get. And then you can see that there are many areas of opacities, or more like patchy consolidation and haziness. This is due to bronchitis. The bronchioles, the bronchi, all of them, they are full of mucus. There is mucus plugging, especially over here, and there is inflammation as well. That is why no clear lung field can be seen. Now coming to the main topic, which is pneumothorax. How you are going to identify pneumothorax. When you want to see pneumothorax, you are going to look towards the periphery of the lung. And here you're going to notice that in some areas, there are absent lung markings, like in this area. So you can see that a lung marking starts from here, for example, this one, and it goes down, but it is absent over here. It has stopped over here. And it is more black in this area. So this is a sign of presence of air in this area. Similarly, you are going to see a well demarcated rim of lung, which you can see over here. You can trace this border, and as you trace this, as you go along with it, you can actually see the shape of whole of the lung that has been collapsed. Now why the lung collapses? Basically what happens is that whenever there is a puncture within the lung, the air tends to accumulate within these spaces known as the pleural spaces on each side, which is present between the parietal pleura and the visceral pleura. And as the air accumulates in these spaces, this air, it pushes the lung. And as it pushes the lung, and as the air is removed from within the lung and accumulates within the space, so just like a balloon deflates when air escapes from it, the lung also deflates and it becomes smaller in size as compared to the normal lung, which you can see over here. So this is a case of pneumothorax. There are different types of pneumothorax, and they're broadly classified into traumatic pneumothorax and spontaneous pneumothorax. Traumatic pneumothorax is a result of trauma, whereas spontaneous pneumothorax means that the lung has ruptured without anything causing trauma to the lung. It can be further divided into primary spontaneous pneumothorax and secondary spontaneous pneumothorax. Primary spontaneous pneumothorax is in a patient when there is no underlying condition. So there is no associated history of a long-standing lung disease, whereas secondary pneumothorax occurs in patients with underlying lung diseases, and most commonly it is COPD. Spontaneous pneumothorax should be treated as secondary in patients who are more than 50 years of age with a significant history of smoking or with any evidence of underlying lung disease on examination or on chest X-ray. Other conditions associated with secondary spontaneous pneumothorax include TB, asthma, pneumonia, sarcoidosis, malignancy, bronchiectasis, or even pulmonary fibrosis. So, what are the important clinical features? The patient is going to present to you with typical symptoms of difficulty in breathing, dyspnea, increased respiratory rate, tachypnea, and chest pain. On chest examination, you will see that there is decreased expansion on the affected site and reduced vocal fremitus or tactile fremitus, increased resonance on the affected side, and also on auscultation, the air entry is reduced on the affected side. What is the gold standard investigation for pneumothorax? CT scan can be regarded as the gold standard investigation, especially for the detection of small pneumothorax and its size estimation. It is useful in the presence of surgical emphysema and bullous lung disease, and also to identify any aberrant or incorrect chest drain placement. This management chart is based on British Thoracic Society's guidelines of management of a pneumothorax, and it says if a patient presents to you with spontaneous pneumothorax and if it is bilateral and the patient is hemodynamically unstable, you proceed to place the chest drain. Or in a different scenario, if the patient's age is more than 50 and significant smoking history, evidence of underlying lung disease on exam or chest x-ray. If that's a yes, this is a secondary pneumothorax. Next, you have to see the size of the pneumothorax. If it is more than 2 centimeter or if the patient is breathless, then you are going to place a chest drain. And this is the size of the chest drain that has been mentioned over here, but you can place a chest drain of 28 to 32 French, right? This is the size which is usually used in pediatric patients. Now, if the size of the pneumothorax is not more than 2 centimeters and the patient is not breathless, this means that you can do either aspiration with a 16 to 18 gauge cannula, or if the size is even less than this, even less than 1, यानी कि size 1 to 2 centimeters नहीं है, then you have to just admit the patient and you have to provide them with high flow oxygen and observe for 24 hours. On the other hand, if there are no features of secondary pneumothorax, then we label it as primary pneumothorax. And if the size is more than 2 centimeters and if the patient is breathless, then we are going to aspirate it. If the aspiration is successful, then we consider discharge and view in OPD in 2 to 4 weeks. If the aspiration is not successful, then we have to insert a chest drain. The important thing about insertion of chest tube is the triangle of safety. This is the safe area where important structures within the chest wall do not get injured. It is bordered anteriorly by the lateral edge of pect major, as seen over here, posteriorly by the lateral edge of the latissimus dorsi, superiorly by the base of the axilla. So this is the base of the axilla. It is inferiorly bordered by the fifth intercostal space, which lies horizontally at the level of the nipple. This was all about pneumothorax. What is pneumothorax? How to identify pneumothorax? What are the different types of pneumothorax? Causes of pneumothorax? Its management? And the important things related to chest tube insertion. I hope you understood this. If you have any queries, please let me know in the comment section below. Thank you.